We're going to review the basic principles of neuropharmacology. Neuropharmacology is the study of drugs that will alter the processes that occur in our nervous system. And these neuropharmacologic agents can be divided into two broad groups. We have our PNS and our CNS, or peripheral nervous system, versus our central nervous system. And these drugs produce effects that are equivalent to those that are produced by excitation or suppression of neuronal activity. So we're either getting one or the other. Because of the nervous system and its participation in the regulation of all our body processes, or practically all our body processes, then you can think about all bodily processes being influenced by drugs that alter neuronal regulation. So we're either mimicking or we're going to block neuronal regulation. Neuropharmacological drugs can modify these diverse processes, such as the skeletal muscle contraction that occurs in our body, cardiac output, vascular tone, respiration, GI function, uterine motility, glandular secretions, and functions that are very unique to the CNS itself, such as our ideation, our mood, perception of pain. But given the broad spectrum of these processes that the pharmacologic drugs can change, and given the potential benefits that can be gained by manipulating these processes, it's without surprise that we use these widespread drugs in clinical applications. We're going to go through the basic mechanisms, first starting with the sites of action. Is it an axon versus a synapse? And to influence a process under neuronal control, a drug can alter one of two basic neuronal activities. It's either axonal conduction or it's going to be a synaptic transmission that's occurring. Most neuropharmacologic drugs will act by altering synaptic transmission. There's only a few that will work on the axonal conduction. But this is to our advantage. The drugs that alter synaptic transmission produce effects that are like selectivity of these drugs producing exactly what we want it to do. Like we have more control over it because there's much more selectivity, right, than the axonal conduction. So we do prefer the synaptic transmission in terms of the site of action. But we will talk about axonal conduction. Now, these are drugs that act by altering axonal conduction, and they aren't selective. Think about the process of conducting an impulse along an axon. It's the same in all neurons. It's not very different or unique. And because of this, the consequence is that the drugs that alter axonal conduction don't affect conduction in all the nerves to which it has access. So it can't produce a selective effect. Local anesthetics are a type of drug that decreases axonal conduction. And because these agents produce non-selective inhibition of axonal conduction, they're suppressing the transmission in any nerve that they're able to reach. And therefore, we have local anesthetics that are very valuable. And we use them, for all different reasons in healthcare, but the indications are going to be limited because they're not selective. In contrast, though, the drugs that alter axonal conductions, we have on the other spectrum drugs that alter synaptic transmission. And synaptic transmissions produce highly selective effects. And they occur because the synapses differ from one another, where the axons do not differ. And this is why the synaptic transmission is highly selective. We have synapses at different sites that employ different transmitters. And in addition, for most of these transmitters, your body is going to have more than one type of receptor. So if you're using a drug that selectively influences a very specific type of neurotransmitter receptor, then you're only working on changing that action. And we can only alter one neuronal regulated process. Therefore, we're leaving the other things unchanged. This is what gives it its selectivity. And there are many uses for synaptic transmission in terms of our neuropharmacologic agents. we are going to talk about in depth now the steps that occur in synaptic transmission. And this is going to help you understand how the drugs alter the receptor activity. It's going to take place in a very orderly fashion. And because we're using drugs to modify these steps, then this is what's going to influence that receptor function. So the first step is transmitter synthesis. For synaptic transmission to actually occur, the molecules of this transmitter have to be available in the nerve terminal. You look at the transmitter synthesis as the first step in transmission. Now you can see that we also have to have, and in the figure itself, if you look at QRS, this represents the precursor molecules that have to happen before we can get to the T or the transmitter. So we need these molecules to transmit T. Then we have storage. Transmitter storage is the second step. Once we have a transmitter that's synthesized, and we have it synthesized through this process here, then it has to be stored somewhere until we can release it when needed. So this transmitter storage takes place within the vesicle itself. They're tiny packets that are present in the axon terminal. And each of these nerve terminals contains a large amount of transmitter-filled vesicles that are storing these transmitters.
Next, we're going to talk about the steps 3 and 4, transmitter release and receptor binding. The release of the transmitter, this is triggered by the arrival of the action potential, and this occurs at the axon terminal. Once this potential initiates the process, the vessel is going to undergo a fusion with the terminal membrane, which causes the contents to be released into the synaptic gap. The action potential will only cause a small fraction of the vesicles, though, to present the axon terminal to discharge the contents. So it's not everything. Once these transmitters are releasing, the molecules will diffuse across the synaptic gap and then undergo this process of reversible binding to receptors on the postsynaptic cell. This is going to initiate this cascade of events that will eventually result in the altered behavior of that postsynaptic cell. Step 5 is the termination of transmission, and this is going to be terminated by the dislocation of the transmitter from the receptor. It's going to break apart, and it's going to be followed by the removal of free transmitter from the synaptic gap. It can be removed from this gap by 3 different processes, either reuptake, enzymatic degradation, and diffusion. In synapses where transmission is terminated by reuptake, we have the axon terminal, which holds a pump that transports this transmitter molecule back into the neuron from where it began or where it was released. Now, after reuptake, the molecules of the transmitter can be degraded and then repackaged to put back into their vesicle and reused again later. In synapses, though, where transmitters are cleared by degradation, the synapse contains large quantities of transmitter inactivating enzymes. Lastly, although simple diffusion away from the synaptic gap is a potential means for terminating this action at the transmitter, it's a very slow action, and generally it doesn't have very much significance overall. So more importantly is understanding the reuptake and the enzymatic degradation that can take place. So what are the effects then of drugs at the synaptic transmission? All neuropharmacological agents, except for our local anesthetics, are going to produce effects either directly or indirectly altering the receptor activity. The way in which drugs alter receptor activity is by interfering with that synaptic transmission. And because this transmission has multiple steps, that allows these drugs to have several potential targets to work on. you have to understand what drugs do at the specific receptors just generally. And so, from a very broad perspective, when a drug influences receptor function, the drug can just do one of two different things. It can either enhance the receptor activation or it's going to reduce the receptor activation. This term we're talking about, receptor activation, this means that it's the effect on the receptor function that's equivalent to that which is produced by the natural neurotransmitter at that particular synapse itself. So, for instance, when a drug affects by mimicking the natural transmitter, then it would increase receptor activation. But when we have a drug that's reducing the amount of natural transmitters that are available for binding, then we're decreasing receptor activation. Receptors and the activations, they don't necessarily mean that all the physiologic processes are going to go faster. When we say receptor activation, it can also make it go slower as well. I'll give you an example. The heart. The heart's going to decline when there's an endogenous neurotransmitter of acetylcholine that activates the cholinergic receptors on the heart. Why? Because this drug is mimicking acetylcholine at the receptor of the heart, causing it to be slower. You can use this table to help you to understand what should be expected, the effect on the receptor activation. So for instance, these are the different steps or stages that we talked about of synaptic transmission. If you have a drug that works on the synthesis of the transmitter, we first have to understand, is it increasing or decreasing that action? If it's increasing the synthesis of this transmitter, then it's also going to increase the receptor activation. If it decreases the synthesis, then it's decreasing the receptor activation. If we have a drug that works at the site of termination, when there's a blockade of reuptake, then we're increasing the receptor activation. When we're inhibiting the breakdown, well, we're also going to increase the receptor activation because it's at the termination of transmission. So each of these are going to be a little bit different depending on what is happening at that step. Okay. The ability for a neuron to influence the behavior of another cell really is going to depend on how the neuron is able to alter the receptor activity of that target cell. Because neurons alter receptor activity by releasing these transmitter molecules. They diffuse across the synaptic gap, they bind on the receptors at the postsynaptic gap. But if your target cell doesn't have the receptors for that transmitter, then once the neuron is released, nothing can happen, right? There's no effect because we don't have the correct receptor to receive it. If you understand that, you can understand the effects of neuropharmacologic drugs because, like the neurons, it really depends on being able to alter receptor activity. No matter what the precise mechanism of action is, the neuropharmacologic drugs work by influencing receptor activity on target cells. And this concept is central to understanding all the actions of the neuropharmacologic drugs or the mechanism of actions of these drugs. So let's understand it again. I'm going to say it a little differently. The effect of the drug on a process that's regulated by these neurons is dependent on the ability of that drug to directly or indirectly influence the receptor activity on that target cell. But remember, selectivity is also important. Selectivity is one of the most desirable qualities that a drug can have. If you have a drug that's selective, it is much better than a drug that's unselective because it can alter a specific disease process and it leaves the other physiologic processes in your body largely unaffected. But when you have drugs that are unselective, then it, yes, could potentially target the disease process you're looking for, but it may also alter other physiologic processes as well. Many of the neuropharmacologic agents have a high degree of selectivity, and this is possible because the nervous system has multiple types of receptors and it regulates processes under its control. And the relationship between the multi-receptor types and the selectivity of or the drugs in the neuropharmacologic category are illustrated by understanding, do you have that receptor, or do you do you have the receptor, and then also, is the drug selective or not? Okay, so we are going to illustrate this by this concept of MORT and MERV, which we're going to talk about in the next slide. Okay, so remember though, our patient MORT has 4 functions: pumping blood, digesting food, shaking hands, and emptying the bladder. Let's look at MORT. Okay, so here are both MORT and MERV. And in this illustration, you know that MORT is healthy. Now, he has one type of receptor that regulates all the various things in his body, receptor A. His heart, his gut, his bladder, and we'll call it his musculoskeletal system, or his hands, right? So the hand shaking. So there's no issue, but he has one type of receptor to regulate all the various functions. But there's no problem because he's healthy. Selective physiologic regulations can be achieved simply by just sending impulses down the appropriate nerves because everything's working well. There's no need for increased cardiac output. There's no need to send impulses to the nerve, to the heart. There is no need to change the way digestion is happening. Okay, so you get it. He's healthy. Now, having one receptor type is no disadvantage when your patient is completely healthy, but what if he gets sick? And then you need to just treat one of these target organs, but they all have the same receptor. So it's going to create a therapeutic challenge because you're trying to provide a drug that's trying to, let's say he develops cardiac heart failure, you're trying to provide a drug that will work to increase cardiac output. But unfortunately, because he has the same receptors on all the different target cell organs, when you're giving something to help with cardiac function, you're also stimulating his other organs too, positively or negatively. So consequently, in an attempt to improve cardiac output, you're going to have side effects. And they can range from let's say compulsive handshaking, right? Keeping in with our example here with the A receptor on his hand. Or it could be enuresis or incontinence on the bladder. GI, maybe you're going to increase his risk for gastric ulcer, or he just feels, or maybe gastric bleeding, or nausea, vomiting, diarrhea, right? Because we're not just working on the heart. Lots of different side effects can come into play where we have these undesirable effects as we're trying to get the desired effect on receptor A. But let's look at MERV. Okay, MERV's a little bit more complicated in terms of that he has different types of receptors. He can control each of the same 4 functions that MORT can, but by employing different specific receptors. So in this case, if MERV had heart failure, and we can now use drugs that are selective for receptor A because they have different receptors. And when we use a drug that is selective for A, it's not going to complicate or interfere with the reactions and the functions and the physiology of B, C, and D receptors. So this is good, right? Selective, the ability, the selectivity to enhance his cardiac function without risking the side effects is better than MORT, because MORT, there's going to be side effects because he has the same receptors. Okay, now how do we do this? If we administer an agonist agent that binds selectively to the receptors of the heart, then it's working just on that A receptor. It's not going to interact with B, C, or D. because these actions and functions of the other target cells and organs aren't affected by receptor A, giving a medication that only works on A helps to produce more of a selective effect, reducing side effects. So we can conclude then by Morton and Merv that the more types of receptors we have to work with, the greater chance that we can make and use selective drugs. And now we can produce selective drug effects. Okay. Now, in general, to understand any particular peripheral nervous system drug, you have to have 3 types of information. We need to know what type of receptors that the drug is going to work on. We need to know what the normal response is to activating these receptors. And then what are the drugs will actually, like, what will they do at that receptor? Okay, so again, we need to know the type of receptors that the particular drug can work on, what's the normal response if we activate the receptor, and what the drug in question does to this receptor function. Will it increase or will it decrease receptor activation? If you know these 3 things, then you can predict what effect that particular drug may have on your patient. So we're going to illustrate this concept using a specific drug, isoproterenol. This is the information you need for isoproterenol. We need to identify the receptor where isoproterenol acts. So we collect this information. It acts on the beta 1 and beta 2 adrenergic receptors. Okay, but now we need to know the normal responses to the activation of these receptors. For instance, what will happen if beta 1 and beta 2 adrenergic receptors get activated? Prominently, the response to the activation of beta 1 is going to be increasing the heart rate, increasing force, contractility, therefore cardiac output. And the primary response for the activation of beta 2 is going to be bronchial dilation and elevation of blood glucose levels. The last thing we need to know is whether isoproterenol will increase or decrease the activation of beta 1 or beta 2. At both of the receptors, isoproterenol will cause activation. Now that we know all these 3 pieces of information, we can predict what will happen if we prescribe this medication. So, by activating beta 1 and beta 2 receptors, isoproterenol can elicit 3 major responses. It will increase your cardiac output, and this is done by increasing heart rate and force and contractility. It's going to also, though, dilate the bronchi, and it's going to elevate your blood glucose. Okay, so we know it can potentially have 3 effects. Now, I want to challenge you. If you have a patient that we need to increase cardiac output, but we also know that they are a type 2 diabetic patient that is non-compliant with their medication, you may reconsider using this specific medication because we know that it also activates on beta 2 receptors that potentially can elevate blood glucose. So again, if it's not selective enough or it doesn't have the high selectivity that you require depending on your patient's comorbidity, you may see adverse effects for that patient or contraindications for use.